Today, I'm talking about a contemporary approach to early and advanced breast cancer. So lecture is an opportunity to cross-pollinate. So we have a whole lot of attached YouTube links where you can learn different techniques and see how we do things in the unit. But obviously we're looking for feedback on how you do things so we can learn too. I'm going to talk about clinical tips from radiology to survivorship, looking at various aspects from clinical path radiology review through to decreasing your theatre times, little tricks with sentinels, oncoplastic, right the way to can we avoid surgery today. So I want to start with translational radiology. More times than not, you are presented with a radiology report and you read the report and then plan how you're going to treat your patient. And I want to stress to you the concept of a unit radiology MDM. I call it CPR, and we all understand the term CPR, but it's actually clinical path and radiology review. You must have a look at specialist ultrasound to see if there's nodal involvement with the cancer. Watch judicious use of MRI scans and overreading. There are many radiology units. We have to audit the number of biopsies done, positive and negative, as well as self-referrals. So here's an example of screen-detected disease where biopsies have been done, and you can see these massive hematomas. So there's no such thing as an emergency core biopsy. You need to understand the costs up front. Some of these valves are incredibly expensive. If it comes back as benign, it's taken out of patient savings, and there's a large amount of money wasted. We need to radiology review. We need to work out when we should do the biopsies, should we do the biopsies, and what the costs and alternatives are. This does not mean that we must have what happens on this slide. Because there's no screening or chain of command, oftentimes patients see radiologists and they have a little note to say palpable lumps should be excised and biopsied for definitive diagnosis. In this day and age, there is no role for surgical biopsies to diagnose any breast cancer. 95% of the time it should be done on core needle biopsy, but again, judicious use of CPR. I want to stress the important role of the pathologist. We understand TNM, size, the importance of size, big tumors, ugly tumors, etc. But it's actually really more around personality and biology, and that's why we have our Avengers there below, and we have our big Hulk, and our different types of special types of cancers we need to understand. So the role of the pathologist has changed since 2011, where we started looking at genetics and pathobiology, and we changed from morphology to biology. We now call our tumors NST, and we need to understand luminalities, AB, HER2 enriched, and a new classification for triple negs. This has been further enhanced by genetic profiling of tumors, both in the node negative and select node positive environment. So we now have a changing role in cancer diagnosis. So our pathologist, the chef in CPR, was initially the diagnostician. Now he prognosticates with working out biology, and we will have another lecture later on his ability to predict response and gene sequencing. Innovations in radiology have moved a long way. We now have tomosynthesis, we have contrast enhanced mammography, which we have available at Helen Joseph, elastography from an ultrasound point of view, and MRI. I think here's a nice example of a contrast enhanced mammography done at Helen Joseph, where a patient had an unknown primary, and you can see the primary and the node on the contrast enhanced very nice and easily here. So the future is in breast imaging and AI, and we have currently 4 sets of research going on between the 2 different units on AI and deep learning of computers around how we can change our ability to diagnose and also predict and map out where we're operating and what we're doing. And for this, our BioVision is great. So from there, we move on to how we can decrease time in theatre. A field of interest for me is this concept of ERIS, enhanced recovery after surgery, and improving patients' outcomes, particularly around oncology and the immune suppressive effect of oncology. So if you have aspect to radiology real-time machines like we do, the BioVision, you can real-time map out exactly where the tumor is and your margins. We also use aspects such as magnetic seed localization, so you can work out exactly where the tumor is, and obviously, if you're fortunate, intraoperative pathology. So different ways of theatre localization are radioactive seed localizations, and what I like to use is magnetic seed localization. And you can place this in nodal recurrences, and we have a first in Africa paper on that. We can pick up a recurrent node, and here is 6 months down the line post chemo. You can pick out exactly where the tumor is. You can mark deep tumors. You can work out your distance from your margins with these magnetic localization devices, and we have some live surgery for you to see on this in one of the linked videos. I next want to talk about the evolution of the sentinel lymph node, and again we have an attachment on tips and tricks that you can use. Most people today should know how to do axillary sentinel lymph nodes. We understand the axilla takes 75% of the drainage, but a full dissection causes morbidity. Whether you use isotope, whether you use blue dye, or what I like to use is magnetic tracers, you must know the techniques about doing a sentinel. So we use MagTrace, which can be placed radiologically or in theatre and can last up to 30 days, and you can very nicely work out exactly where your sentinel is. So sentinel lymph node biopsy is about experience and expertise, and again I suggest you attach to the link in the video if you feel you do not have this, and you're welcome to come to Helen Joseph to practice and enhance your skills. So it shouldn't be a just taught and see. It's not see one and do one. We need to understand trends and trainings around this. So the new tribulations around sentinels is the marking of the nodes in the positive axilla. We both at Helen Joseph and at Mill Park do mag-seed nodal marking, which means we can mark the sentinel pre-chemotherapy and then do a sentinel on sampling. This is called the targeted axillary sampling, and it's exactly what they're doing at MD Anderson. The biggest challenge for surgeons is to realize that the sentinel is a tool, that breast cancer is a systemic disease, and the information you gain determines oncology treatment and order. It helps you with reconstruction and radiation requirements. I want to move from here to talk a little bit about breast reconstruction. So oncoplastic surgery is something that most people with a special interest in breast should be able to do up to different levels, and training varies in different units, and we provide training on all aspects of oncoplastic surgery. The first thing I want you to stand away from is this concept of doing an elliptical cut in the upper outer quadrant of the breast. If you do a cut from the nipple towards the axilla, what you can do is you can then use rotational flaps really easily. So here are examples of unilateral dermoglandular flap rotations that you can use by just better mobilization. So placements of cuts are critical so that you can mobilize tissue in. Next step is a concept of a bat wing, which is a less attractive reconstruction, but is fairly simple to teach, train from generalists. If you're going to move to further levels of oncoplastic surgery, please train within a unit so that you understand type of breast tissue, ptosis, and issues both patient and disease related, so you don't land up with major complications. The last thing I want to talk about is the concept of a Goldilocks. Now, Goldilocks mastectomy has been well described internationally. We have utilized it more and more because of our lack of ability to get hold of prostheses, particularly in our government environment. But as we've got Dr. Gribnick's details on the bottom there, we've also got a lot of people involved on the private side that are presenting big papers internationally and doing MAds and PhDs around this topic. So it's a full autologous reconstruction. It's a mastectomy with no donor site morbidity. It's radiation resistant. You need to understand your volumes of your breast, and again, we save the nipples here, so you've got to watch nipple congestion and necrosis. So these are examples of Goldilocks in the unit. We go in through the type 4, the lateral limb of the type 4 breast reduction, a full mastectomy, moving up the TE flaps, and again there's attached video that you can see on this. So those are some of the outcomes. Just to show here how thin the flaps are with a mastectomy. It's a full mastectomy. You can actually see through the skin a less than 5 mm distance between the nipple and the underlying removed breast. I want to talk about the fact that the changes that happened in the 1950s. Up to that stage, surgery, it was primarily around the surgeon. Inflammatory cancer was the catalyst that changed neoadjuvant chemotherapy. And I think this is where we realized time zero in the 60s that the use of combination cytotoxic chemotherapies could treat breast cancer and move to central stage. At that stage, we took 5 drugs together, hectic for a patient point of view, but we had a dramatic response rate of 80% in advanced cancers. So the future is, how do you cure cancer with the right drugs? Can you keep the patients alive with aggressive high-dose regimes? Our regimes are less aggressive now, and we need to again understand that it's not about operating in emergency mastectomies on advanced cancers. So your first enlightenment is that each cancer is different, each patient is an individual, so your doctors. It's no longer an era of recipes and regurgitating formulas, and I can't stress how, for me, this COVID-19 has shown that we can personalize cancer care. The team is your multidisciplinary team, and every single patient needs to be discussed in your multidisciplinary team. We've got a nice YouTube on how you can change things around your practice to ensure better functionality, both from patient access to multidisciplinary. The second premise is if biology dictates and cancer in the breast can't kill, only metastases can, you must assess everything up front before rushing into surgery. So you want local regional documentation of everything, local tumor marking prior to starting any treatment. And we do this in different ways in government and private. So here's an example of someone who's had primary oncology care, the gold standard in all locally advanced breast cancers. She actually never even had surgery. So she went from primary chemo to nothing. We can facilitate cosmesis. It's a form of biological warfare. We've got to stop the generalist emergency mastectomy and surgical biopsies. So personalized oncology today means we individualize recipes. We can use TAC for triple negative, TCH for HER2 in the neoadjuvant, weekly Taxol for our locally advanced luminal A's. We see a lot of these in government, and you can actually give the Taxol works very well in this setting. You can use Taxol and Herceptin for your low KI triple positives, as well as primary endocrine therapy, which we use a lot of in both units. So the rules around primary chemotherapy is place markers up front, understand tumor size, multicentricity, document who needs radiation, and if poor responders need second line. So in our practice, all locally advanced cancers receive NSCT or PET. In our subset of patients, we mag seed the sentinels, we mag seed the patients having primary endocrine. Our poor biology tumors, we do sentinels up front, and we do sentinels post-primary chemo as well. In terms of loco-regional treatment, very few people should get a mastectomy today. It's the inflammatory cancers, the multicentric, the Pagets, very few lobulars. Surgical principles are remove the cancer with a clear margin, yield your blade with care. The rules are same for breast conservation and mastectomy. Understand tumor size, tumor location, clip your beds, know when to do a sentinel, and know that an axillary dissection is less than 6 nodes. I have a big concern with the lack of availability of radiation therapy, as this map shows, and radiation therapy is integral today in local and systemic therapy. More people should be getting breast conservation radiation. There's a role of RRT. To radiate for margins is a weak indicator, and I think that should be taken out. We're seeing lots of locally advanced, and patients with any regional nodes need radiation anyway. So to turn around and say node positive disease, do a mastectomy is counterintuitive. Radiation is often third place in that people start chemo and then decide who needs radiation. Again, you want to discuss this up front and understand size, skin involvement, nodal status, and know before you start chemo who's going to need radiation afterwards. It's a travesty of justice when I see the lack of access and availability in our government settings, the shortage of units, the poor compliance, the fact that patients don't have breast conservation because of lack of radiation, the fact that we turn around and say we won't give it if the ejection fraction is low. This is not acceptable. RRT can fill the gap. You can hyperfractionate or RRT. So here's our target system that we work internationally with. It's a movable machine between government and private, and you can give RRT and replace a boost in our locally advanced or use it as a standalone in our early. The next thing I want to talk about is different dimensions. Maybe we shouldn't be operating on all breast cancers. Okay, so let's look at cryosurgery. There's an attached video. You can cryoablate tumors both in the early setting and in the locally advanced setting. So there's lots of data to show. Here's cryoablation in an advanced breast cancer having an abscopal effect and decreasing distant metastases. In conclusion, I want to say we have a rainbow nation. Please join Begoza, be part of a team to make changes for breast cancer in this country. We have a good few multidisciplinary units that offer internationally based care, and yet we still have darker shades of inequality. So in conclusion, I want to ask, what are you doing? How can you and how can we incorporate innovations in breast care, seek new technologies, improve existing technologies to better treat our patients? We can achieve the impossible by doing what's necessary in simple steps at a time. I'm going to again refer you to the links in the videos and point out that medicine is a humble spirit, inquiring mind, and service profession. And thank you to those around me who keep my life going so that I can do what I do. Thank you.